Welcome. I'm Sebastian Mahfood, and you're listening to WCAT Radio, the on-air wing of En Route Books and Media, bringing you the dulcet sounds of Catholic wisdom.
Good afternoon, and welcome to WCAT Radio and this edition of Inter Vitam et Mortem, Between Life and Death, interviews and discussion with a Catholic bioethicist. I am your host, Dr. Anne Urlakis. I am a classically trained and degreed bioethicist, and today I have with me a distinguished guest, Dr. Paul Byrne, whom I wish to introduce to our listeners. Before we begin, let us start as we always do with a prayer, in the name of the Father, and the Son, and the Holy Spirit. Dear God, our Heavenly Creator, you are the author of life and of truth, the reality that you will each and every human person into being, created from the moment of conception, bearing the dignity and imprint of your own image and likeness within the very essence of our being, is a mystery beyond human understanding. Please help us to have a greater appreciation of the gift of being created in your image and likeness. Help us to reverence that reality in our brothers and sisters, especially in the tiniest and most vulnerable among them. Help us to defend the sanctity of every human life, from conception to natural, true death, through the intercession of Our Lady, the Ever-Pure, and All-Immaculate Blessed Virgin Mary, in the name of the Father, and the Son, and the Holy Spirit. Amen. Again, thank you for tuning in to this episode of WCAT Radio's Inter Vitam et Mortem, Between Life and Death, discussion and interviews with a Catholic bioethicist. I am delighted and honored to have as my guest today Dr. Paul Byrne. Dr. Byrne's curriculum vitae is impressive. It is 11 pages long with numerous awards, peer-reviewed publications, accolades, invited presentations, and I fear I will not do it justice by just mentioning a few of Dr. Byrne's credentials. Dr. Byrne is a clinical professor of pediatrics at the University of Toledo, Ohio. He is president of Life Guardian Foundation, the past national president of the Catholic Medical Association, a pioneer in the field of neonatology. Dr. Byrne is the founder and was the director of the NICU at Cardinal Glennon Hospital for Children in St. Louis, Missouri from 1963 to 1981. His many directorships include director and chair of the neonatology at St. Charles Mercy Hospital in Oregon, Ohio, the medical director of the newborn nurseries and pediatric ward, City of Faith Medical and Research Center in Tulsa, Oklahoma, director of neonatology, Archbishop Byrne Mercy Hospital, Omaha, Nebraska, pediatric director, St. Louis University Perinatal Center, Southern Illinois. He was the invited presenter at the Pontifical Academy of Sciences in February of 2005, and he was the organizer and the presenter of the International Congress, The Boundaries of the Human Being at the Time of the Biotechnology Revolution in Rome in 2012. Many more accolades, but I'm going to not take the time to continue with his credentials. I want to introduce him to my listeners. So welcome, Dr. Byrne. Thank you so much for taking the time to join us here today.
Thank you for having me. Yes, I to acknowledge some of the things that I've had the privilege to do in my life is nice, but what's most important is the things that we talk about tonight, and what then is most important are what we can do about them. And I don't mean limited to just you and me, but each one of us has to find a way to protect and preserve life. And as you mentioned, from conception until true death. And so it's important that we get on with the interviews so that we can bring up some of the topics and stimulate the interest of, between us, but then also among our listeners so that they can do things to protect and preserve their own life and the life of their families and loved ones.
Great. Thank you so much. When we first began talking days ago, and we've had several phone conversations here and many emails going back and forth, I was intrigued you were a pioneer in the field of neonatology, and you mentioned to me developing that blood pressure cuff that is used in neonatal nurseries all over the world by working with the astronauts and technology transfer, taking what was used as a finger cuff and moving it to newborns. Can you talk a little bit about your early work in neonatology and where that has led you now?
Well, what was going on is I was a practicing pediatrician, and when a premature baby was born, if the baby had trouble with breathing, we would come back to see the baby the next day, and many times have to pronounce the baby dead. In fact, I reviewed the statistics at 2 hospitals for 2 years, and there were no survivors of babies 1,500 grams, that's 3 pounds and 4 ounces, who had trouble with breathing. And so it just seemed to me that there should be something that we could do. So we started at Cardinal Glennon Children's Hospital, and at first we had an 8-bed room, and we called it a special care nursery because the words neonatology, neonatal intensive care unit, they did not exist at that time. The fact of the matter is, there were really no treatments. The only thing that we would do is we would put a catheter in the umbilical vein and give the babies glucose and bicarbonate to counteract their acidosis. But we had no treatments. We had no ventilators, and the fact of the matter is, some people laughed at what we were doing and said babies can't survive, can't do any of those things. And I said, well, we'll try. So so far as the blood pressure cuff is concerned, they had a large section of the newspaper, Sunday newspaper in St. Louis, about the astronauts and the capsule that was used to send men into space. And I wrote a letter to Mr. McDonald and said, "Dear Mr. McDonald, you put people into space and you take their blood pressure, and I'm here at Cardinal Glennon Children's Hospital, and we have no way to do blood pressure on premature babies." So he sent 2 electronic engineers, and we went to work. I had my stethoscope. They had their oscilloscopes, and what we did is I took the blood pressure cuff that was used on the finger of the astronaut and moved it up to the arm of the premature baby. The premature baby would not hold still like the astronauts did while they took the blood pressure, so we had to use electronic gating. We would measure the circulation time from the beating of the heart out to the arm, and then open up the microphone only during those milliseconds. And so the cuff that we used, that was used by the astronauts, it's very same or similar cuff that's used to take blood pressure on babies and infants throughout the world. It's a little different design as time went on, but it's basically the same plastic cuff that was designed initially for the astronauts. And so that was exciting, but the more exciting things that occurred in the treatment of premature babies was to find a way to breathe for them. And some of our listeners are on apparatus to help them breathe called CPAP, and sure, continuous positive airway pressure. And that was one of the first things the first advances that were made in the helping babies to breathe, the concept of CPAP. And the fact of the matter is, when I first did it, just used a U-tube attached to the wall, connected by a hose to the breathing apparatus, and designed a way to do that. And so that idea of CPAP, or positive end expiratory pressure, was a great advance in the ventilation of babies. And then later on, the rest of the ventilator was developed. And one of the things that...
And you were personally involved in the development of each of these technologies, yes?
Yes, we did them at Cardinal Glennon Children's Hospital. And the thing that the listeners need to realize is that the ventilator that's used for children and adults essentially throughout medicine, that ventilator was invented for the infants because the ventilator had to be very precise, it had to be very sensitive, and so once it was developed for the infants, well, then it was used. It's used on everybody. Recently, I was in the hospital myself and had the ventilator used on me. It was the same ventilator that was invented for infants. So that was exciting at that time. And we did other things too in our nursery. We were the ones that invented how to give nutrition in the veins of little babies. And we were the ones that identified the need for magnesium and the need for copper and the need for zinc. And while I tell you about those advances, and they were exciting, and I would say that I was one of the leaders in the field, and Cardinal Glennon Children's Hospital was one of those that was leading in the development of ways to diagnose and treat newborn babies and premature babies. And then what happened in my own life is that I had a baby, Joseph, in 1975, who was born very prematurely and was on the ventilator for several weeks. And he wouldn't move and he wouldn't breathe. And we did a brainwave test on him, and his brainwaves were flat. And what's written on his chart is consistent with cerebral death. And so I asked the neurologist about that, and he said, well, repeat it, which we did in 2 days, and it was unchanged. And then he said, well, in some places they turn off the ventilator. And I said, well, I don't do that. I said, I treat babies. Some live, some die, but I just treat them, and I continued to treat Joseph. Eventually, he went to school. He got excellent grades in school. He ran track. He played baseball. He's married and has 3 children. But because of Joseph, that stimulated me to investigate the issues that have to do with brain death. And it was just amazing to me how brain death developed, the concepts of brain death developed, because I was in an academic environment where we were doing our best to use up-to-date science, scientific method to develop better ways to diagnose and treat patients. And what happened in brain death is it was just invented. They just made it up. In 1968, and actually it started at the end of 1967, they did a heart transplant in South Africa and got a lot of notoriety. Some of the older listeners will remember that. But then what happened is 3 days later, they did a heart transplant in Brooklyn, New York. They cut the beating heart out of a 3-day-old baby and transplanted it into an 18-day-old baby. And, of course, the 3-day-old baby, when the baby's heart was cut out, was immediately dead. the 18-day-old baby who received the heart did not live very long. So there were 2 babies dead. It was illegal. It was immoral. And they had to find a way to solve the problem. So what they did is set up a committee at Harvard. It's known as the Harvard Committee. The Harvard Committee, in a few months, published an article titled A Definition of Irreversible Coma. Remember that coma is a word that's very similar to comma. It means it's a pause. It's somebody who's alive, but they're not responding. And so what they did is they translated coma into death. And they invented brain death, and I really call it invented. Other people might use other terms, concocted. And they pointed out how they had to make it legal, so another word would be conjured. But in any event, it was not based on science. Advances in medicine begin often in the chemistry laboratory, or they will begin in the laboratory of some kind of research on animals, and then it's only after that it gets to human beings. And but what they did is they had no basic science studies, and they had no studies on infants. They had no studies on patients, I should say. They had no studies on patients. They just
who were the members of the members of the Harvard Committee? How was the Harvard Committee formed, and why were they given such carte blanche authority to do this?
Because they're given carte blanche authority to do it because they had to find a way to do organ transplants, especially heart transplants. They'd already done it. It was illegal and immoral.
Okay. And
so they had to find a way to make it legal and moral. And so the committee was made up of 13 men. None of them were internists or family physicians, and obviously weighted with neurologists, and they just invented it. They just published it. They had no basic science studies. They had no studies on patients. And me, I was in an academic environment, and then I go to read this, and I have a hard time believing it. And so then I looked at the next article that was published, which was in 1971, which came out of Minnesota, and it is known as the Minnesota Criteria. And when you read that article, they talk about 25 patients, but then when you read it, you find out they did brainwave testing on only 9 of those patients, and 2 of the 9 still had brainwave activity. And their conclusion was no longer were they be required to look at EEG or electrical activity before they could declare somebody dead. And that was really appalling to me. And I asked the neurologists close to where I worked, the ones that I worked with, and they said, well, they know it's not right, but they just don't use it. And I said, well, why don't you write something? Why don't you do something? But they wouldn't. And then the next study that was the collaborative study, entered 844 patients into the study, but they reported on only 503. And they never said why they discarded the other 300 patients from the study. But whatever reason they discarded it, since it has to do with life and death, it would seem that maybe they discarded them because they lived or whatever. But then when you study it, of the 500 patients, the first thing is that 44 of them did not die. They survived. And then those who did die, they did autopsy on about half of them, and 10% had no pathology in the brain. Anyway, that's the so-called scientific basis of brain death. And then
looking at the scientific basis of brain death, we start with a Harvard committee that has an N of 0, and we move to the Minnesota study, which starts with an N of 25 and ends up with an N of 10. And then we end up with the next study, which starts with an N of 844, and a third of them are mysteriously not considered. We have 503, and of those, 44 live. And this is what the criteria of brain death is based upon. That's pretty shocking.
That's how it started, and it doesn't get any better up to the present time, and there's little or no science behind what brain death is. It was just invented to get organs, and you see, there are no organs that are suitable for transplantation from a cadaver. You can get tissues from a cadaver. You can get heart valves, ligaments, tendons. Those
cornea, skin.
Cornea, skin. Skin, by the way, they essentially don't transplant skin. They use the skin for burn dressing, that kind of thing. And so very seldom do they use the skin as transplant. In fact, most of the time when they're involved with skin, they're involved with a lot more than just skin. But and the skin is an organ too, by the way. So tissues can be obtained from a cadaver, and you mentioned corneas. The cornea is a tissue that's different from all of the other tissues in the body. All the rest of the body requires a circulation to supply oxygen. The cornea doesn't have any blood vessels. If there would have been blood vessels, then we would have to be looking through blood vessels. But God made the cornea so it's without blood vessels. It gets the oxygen through the tears from the environment. And so when circulation stops, there's still a longer period of time until the cornea gets so damaged that you can't transplant it. So they have a number of hours after circulation stops that they can take the cornea. They don't use the cornea from cadavers as much as they formerly did, because they have a technique of getting a small amount of cornea. It's only the center 1 or 2 millimeters of the cornea that we used to see, and the cornea covers the pupil, the center part of the eye, as well as the part where the iris is, the colored part of the eye that we can see. So the cornea, compared to how much we used to see, is quite large. So they get a piece of the cornea out from the periphery, and they can put that in a culture medium, in a petri dish, and it proliferates, and so then it gets bigger, and then they use that to transplant to the person himself or herself. And so, but in any event, the cornea is a tissue, not an organ. The organs, the important organ that they want to transplant is the heart, but they also transplant the other organs, the kidney, the liver, the lungs, the pancreas, the intestine. All of those are essentially vital organs, and that's what's transplanted. And while brain death, my for several years, my focus was to educate people that brain death is not based on any kind of valid scientific studies, and also to get them to realize that brain death, whatever they call brain death, and is not true death. Incidentally, there were 30 disparate sets of criteria published between 1968 and 1978, all different, and each one tended to become less strict than the ones earlier, and they were free to use any one of those sets of criteria, which somebody could be declared dead on the basis of one, but yes, would still be alive on the basis of the other. And so all of this is involved with brain death, and it's the foundation for whatever they're calling brain death now. But the significant thing has to do with the organ transplant industry, and it is an industry. It's in 2017, the most recent year that we have numbers. $34 billion was built for organ transplants in 2017. In 2014, they do this studies every 3 years. In 2014, it was $30 billion. So it's a multi-billion-dollar industry. It's larger than the abortion industry. And every time a heart is taken, it's a beating heart that's cut out, and it's a transplant surgeon who stops the beating heart just before he lifts it out of the donor's chest, and then, of course, the donor is clearly dead after that. Every time they get a whole liver, they get the liver the operation begins with a beating heart and circulation. In fact, almost all transplants begin with while the patient has a beating heart and circulation. And so a multi-billion-dollar industry. It's really run by the federal government. They have different committees and different things as they set up to get people to be led away from the federal government, but it's the federal government who runs the organ transplant industry. And sometimes people will ask me, well, who gets all that money? Well, doctors, hospitals, the medical system gets the money. Where does the money come from? It comes, much comes from Medicare, much comes from private insurance, and then some people are able to pay for it in addition to that. So it's a multi-billion-dollar industry, and they really take advantage of people because people think that the donor is dead. The fact of the matter is, when you go to the License Bureau and they ask you, do you wish to be an organ donor, they give you little or no information, and then people, I think the large majority of people think that the donor is dead, that they're dead, and then they say yes to that, when in fact what they should be doing is saying no to that. They should be saying no to organ donation, because whenever an organ is taken, at the beginning of the procedure, the donor is alive. The donor has a beating heart and circulation. At the end of the procedure, especially if it's a heart or whole liver, the donor is always dead at the end of the procedure. And so here I am telling you what's happened in my own life, a pediatrician, a neonatologist trying to find better ways to treat sick babies. And then along comes Joseph, and of course, in modern times, because of that, I am able to help other patients. Baby Alfie in England, when I could not get any doctor in England to go see baby Alfie, I went to Liverpool myself to see baby Alfie. And in our conversation the other day, we mentioned baby Gard. some in the audience, in the listening audience, would remember Jahai McMath. Jahai McMath was a 13-year-old girl in California who had tonsil surgery. Their mother got on the television and pleaded for someone to help her. So I went to California and helped to get her treated. We had to get her out of California to get her treated, but she lived almost 5 years in New Jersey. Then
after she was declared brain dead.
After she was declared brain dead, yes. So I continued to help other patients. We have one case, Aiden Halou in Nevada, that was appealed to the Supreme Court, and of course the father did not accept that Aiden, who was a 20-year-old college student who got abdominal pain, they operated on her abdomen but didn't find any pathology, but she didn't wake up from the anesthetic. And her father did not accept that she was dead. We did go to the Supreme Court in Nevada and got a 7-0, unanimous decision from the Nevada Supreme Court, ruling that they weren't convinced that she was dead either. Sent it back to the lower court, but Aiden, once you get into these things, it isn't just that they don't do anything to help the brain, but they don't do things that are ordinary kinds of treatment for other patients. For instance, thyroid. When the brain doesn't function, it stops making thyroid-stimulating hormone, which makes the patient get deficient in thyroid hormone. And that happens within hours. And thyroid hormone is necessary for the circulation. It's necessary for the brain to heal. It's necessary for the respiratory centers in the brain. And these kind of things are not done. When I get involved, I can sometimes get them done, but it's always late. This is the way that I would look at it. I say always late. We get there as soon as we can. We have Alan, who lives in Montana, who almost drowned about 2.5 years ago, and we got involved with helping him. He lives at home with his mother and father, brothers and sisters, and again, we get into the court system. The court system is interesting because they would not listen to my testimony because they said I was too much of an expert. And then baby Miranda in Virginia, they wouldn't listen to my testimony because they said I did not have a private practice. And so they find ways not to listen to the things that I have to say. And, of course, what I'm saying is not so earth-shattering. It's pretty simple. Is the patient dead when they have a beating heart and circulation? And I think that most people don't realize that that's what's going on. Anyway, I keep on talking. Do you have questions or comments?
You're doing a great job, Dr. Byrne. You're doing a great job. This is a fascinating, terrifying subject, and it is also a very sensitive subject. For those listeners who just stumbled upon this program and may be recipients of transplant, may be parents of someone who has been a donor, this can be a very, very upsetting topic, and I want to be sensitive to those listeners as well. But there is a growing number of physicians, professionals, Catholics, bioethicists who are are saying the same thing that you are. Dr. Alan Schumann out of UCLA published some work in the past decade where he issued a critical challenge after going through records and finding that if one is to be considered brain dead, then theoretically they must have died immediately. And in his evaluation of records, he found no, they lived for weeks at times, they lived for up to 10 years at times. And that caused him to rethink things. Father Nicanor Ostrioko is another. I listened to a presentation of his today, and he talks about different criteria for death that we've used all of these tests, as you say, and many of them are in conflict. They put the water in the ears and see which direction the eyes go, but all of them, there are conflicting criteria. And he talked about the autopsy results of a individual that he had access to. This was a child, TK, who had an unfortunate accident at 4 years of age, was declared brain dead. He was released from the hospital on a ventilator to his mother's care. He lived in her basement on a ventilator with nursing care, being fed Ensure for 20 years when he died of cardiac arrest. Looking at his autopsy results, the brain was clot, and it would have met the criteria for brain death. But yet, there was still an individual who grew, who managed to maintain his own blood pressure, and all sorts of other criteria that make it very difficult to see that the brain death criteria would be legitimate. And he is another that is sounding the alarm. Editorial by E. Christian Bruger in the Catholic Thing recently spoke of some of these matters too. So you're not alone in sounding the alarm. My first master's work was on the use of anencephalic infants as organ sources, and I had come down strongly on the side of life in my first master's. Anencephalic infants are infants that are born with a portion of their skull missing and with varying degrees of brain tissue present. And I argued that these children, there is a sanctity of life. They ought not be used as donors. Clearly, donor isn't even the appropriate word because they could not consent to this, that their life, however limited, was worth living. And they would often have met the criteria for brain death based on the different criteria that have been out there, and yet some of these children have lived to 8, 13 years of age with true anencephaly. So this is a fascinating topic. One of the areas that I know that you are expert in, before I get to that point, one of the areas that I know that you're expert in is the apnea test. And that is one of the criteria that is often used. I know that those who are sounding the alarm are finding difficulty in getting their results published anywhere. As you say, there is an industry out there. And if we are to look at this scientifically, if we are to look at this in terms of the weight of empiric evidence, one would argue that peer-reviewed journals should be willing to take articles that challenge previous assumptions, especially when those assumptions are based on erroneous results or very, very small sample sizes, as you indicated before. But that's not what you and the others who are sounding the alarm are finding. They're finding a great difficulty in publishing in peer-reviewed journals these topics. Could you tell me a little bit about the apnea test?
Well, actually, it's called the apnea test, but it's actually a procedure. And just to compare, you mentioned a little bit ago about the ice water in the ear, that what that is a test for the function of the ear and the eye, where they put ice water in the ear to observe whether the eye moves toward the side of where the ice water is, but that's a test where you make an observation. The apnea test is a procedure, and it's a procedure done by taking away the ventilator. Ventilator, by the way, is the correct term for the machine that we use to help people to breathe. It's a ventilator. It's commonly called a respirator, but it doesn't respirate anything. The ventilator just moves air, and you can understand ventilation because we have ventilation with our air conditioning systems. We have ventilation when we open the windows. It moves air. That's all it is. And the ventilator that we use to help people to breathe, the only thing the ventilator does is pushes the air in. And, of course, as we breathe, air goes in and air goes out. But the only thing that the ventilator does is pushes the air in, and it's only the living person who pushes it out. God made the lungs and the diaphragm and the muscles of breathing. In some ways, they have elastic properties. In some ways, it's similar to a rubber band. If we have a rubber band laying on the desk, it's not doing anything. But if we pick it up and stretch it and then let it go, it contracts and it bounces back. That's an elastic property. Elastic properties are things that have elastic properties. They can store the energy. So when I stretch the rubber band and it snaps back, it's snapping back because of the energy I use to stretch it. That's the way breathing is. It's the way it is in you and me now. Our muscles contract to take in a breath, and then they store the energy to blow it out. Well, that's what happens with the ventilator. The ventilator just pushes the air in, and then what has to happen is the next phase of breathing is that the oxygen has to get into the blood, and then the next thing has to do with the heart circulating the blood to the tissues where oxygen is delivered and carbon dioxide is picked up, and then it gets back to the lungs where it has to get out of the body. But the ventilator just expands the chest, just pushes the air in, expands the chest. All the rest of the breathing is done in the living person. It cannot happen in a corpse. But what they do with the apnea, the procedure, the apnea test, they take the patient who is dependent on the ventilator for life support. They take away the life support, and they take it away not for a few seconds or a few minutes. They take it away for 10 minutes. For 10 minutes, they suffocate the patient. They make the patient and they say, well, we give them extra oxygen. But what happens is the carbon dioxide builds up. And when the carbon dioxide builds up, that's toxic to all the tissues. And so far as the brain is concerned, increase in carbon dioxide makes the brain swelling get worse. And so the apnea test procedure is something that really should never be done on any patient. And the listening audience has to learn that if they have a relative that's in the hospital on a ventilator, they have to instruct ahead of time no to the apnea test. Now, to put some things in perspective so that people remember, the machine is called a ventilator, not a respirator. Respiration is the exchange of oxygen and carbon dioxide. The machine does not do any respiration. It only does ventilation, and it only moves the air in. It doesn't move it out, and so when they stop the ventilator, that increases carbon dioxide, which is suffocating the patient. So they have to learn no to the procedure of the apnea test. Now, just so you know, what happens is that in clinical practice, they say they don't have to notify the relatives about doing this test, that they can just do it. They say, and they justify this, they say, well, we don't have to notify the relatives when we declare somebody dead, dead without breathing, without circulation, clearly that way. They don't have to, because it's obvious, the patient's not breathing, there's no heartbeat, there's no response kind of thing, and it's obvious, but it's different.
Cardiopulmonary death.
Yes, it's different with the apnea test. And so I think that they ought to be informing the relatives what the test is, and they ought to inform the relatives that they take away the life support when they do it. Take it away, not for 1 minute, not for 2 minutes, but for 10 minutes. And it's the kind of thing that everyone should learn no to the apnea test. So there's two no's.
We look at the principles of medicine and principles of bioethics, and the first is primum non nocere. At the very least, do no harm. This is, as you say, misnamed test because it's a procedure, but it has absolutely no benefit, no beneficence to the patient themselves, and it is merely for the purpose of declaring them dead so that somebody else may use what is vital to them. It can do nothing but harm in the sense that it takes somebody's life.
Yes.
And if the patient survives, they're surviving after being deprived of oxygen, suffocated, as you say, for 10 minutes. And all the other natural processes then begin to take place, as you had mentioned to me before, the thyroid hormone and what's happening there, the bicarb, and all of the other biochemical processes that occur because of the stress reaction of having this insult to the brain occur.
Yes, you're responding.
If there was any healing that had begun, it reverses it.
Right. Now, just to make sure that we don't, make it clear, that when they take away the ventilator, the carbon dioxide builds up, but they give them extra oxygen. So they would, the people doing this would say they're not making them suffer a lack of oxygen. Because they give the extra oxygen so that the body uses what they give them ahead of time, and they sometimes continue to blow oxygen down the endotracheal tube. I really doubt that it gets absorbed in any way because there's no movement of the lungs. But in any event, the procedure of the apnea test suffocates by increasing carbon dioxide. And but your other analysis, the ethical analysis, is a proper response, and you as an ethicist can readily identify with that. Where are the other ethicists? What are they doing? And I want to emphasize that I graduated from medical school in 1957. And the challenge with patients was to make a diagnosis and then to have a treatment. And every patient got treated. There were no patients without treatment. In fact, the matter is, every hospital had a clinic so that if patients couldn't pay, they paid for them. Every doctor took care of patients. If they couldn't pay, the fee was reduced so that they could pay, but everyone had treatment and care. And then what happened, medicine changed dramatically in the 1960s with this subject that we're talking about, they invented brain death in 1968. Medicare was invented and started in 1964, and then there's other events that go on right around that time, late 60s, 70s, and those things changed medicine. So we have a practice of medicine now, so that when you go to the doctor, he spends almost all the time checking things on the computer. He hardly ever sees the patient. Several years ago, I had kidney stones, and I saw at least 4 different doctors. Now, one of them palpated my abdomen. Of course, they had the x-rays that showed where the kidney stones were, where the stones were, and I don't deny that, but the medicine changed in 1968 with the invention of brain death, and many of the problems that many people see in medicine now, they're related to that change, because what happened is the doctor could call somebody dead when they had a beating heart in circulation, and everybody knows that that's not true death, and yet as they accepted it and propagated it more, they get more and more people thinking that that's the way it is, and so medicine changed greatly. There were some other things that went on at about the same time, but for
Humane Vitae and the repudiation and the introduction of the birth control pill, and the belief that the human person, the change in the anthropology of how we view humanity itself, rather than a gift from God, a burden. It used to be that the view of death was the disintegration of the body and the soul, and that the human soul created in the image and likeness of God, the human person was inviolable, that there was an inviolable dignity. And once the secular world and the theological world completely separated, we have two paths that are divergent. In the secular world, it no longer matters whether you have a person, a soul, and body. It has come down to a subjective analysis whether this life is worth living, and that subjectivity is a committee decision. It is no longer viewed as we in Catholic bioethics view it as this is a human person. This is an entire human person. Also, there is the concept that we look at conception as the moment of the beginning, as when soul and body, human person begin. And it is a moment. It is an instant. It's not a process. It doesn't happen over time. It's a moment. We look at death, and death has always been a moment. One can be dying for weeks, for months, for years. One can be in hospice for a year. But the moment of death, the moment when heart and lungs stop, when we have cardiopulmonary respiration stop, that's the moment of death, the moment of true death. What we have here with the brain death criteria, one can be dead but not really dead, and death becomes a very fluid definition. People who are dead can be alive, like the young girl that you took care of. They can be declared dead but actually still be alive. That becomes very confusing, and the value of life becomes cheapened as the value of beginning and end becomes ambiguous.
Yes, I agree with everything you've said, and to go a little bit further with the things that you're saying so far as the death is concerned and how it relates to brain death, what is observed is an absence of the functioning of the brain. We'll just stick with that ice water in the ear. Put ice water in, and if the eye doesn't move, then we say it's a lack of that functioning. It's really not a lack of the function, although that's often said, but it's a lack of what we observe as an absence of the functioning, and we can apply this to shining of light in the eye to see the pupil respond or not respond kind of thing. But what we're observing is an absence of the functioning. But the absence of the functioning does not mean that the function is gone, because all you have to do is restore something, and now the function is back. So it doesn't mean that the function is gone, or many functions, if you use the plural word, and an absence of the functioning does not mean the function is gone, nor that destruction has occurred. And now what you see is we're moving forward in this process. Absence of the functioning does not mean an absence of the function or that there is destruction of the brain or anything else. On the other hand, when somebody is dead, they have destruction, and they have destruction sufficient so that the circulatory system, the respiratory system, and the brain are destroyed, so that those functions will never be back. And so while death is from a theological point of view, the soul separates from the body, but what it gets manifest as in destruction, and so at least those are the things that I would say we have to understand the difference between an absence of the functioning and the function and destruction.
That's a great point. That's a great point. It really is. Yes. You make an excellent point there, and it is the absence of some function, because as was pointed out in the article that I was reading today and the video that I watched, that if we are measuring only certain things, eye movement with ice water, we're missing the fact that this individual is able to sustain their own blood pressure. That is still a physiologic function. Whether others will argue, that's a hindbrain, low level function, it is still a function, as is growth and development. And this individual that was 4 and died at 20, both limbs grew at the same rate. There was normal function there, but that function didn't count toward the determination of death. A corpse does not grow. And a corpse does not maintain blood pressure. And as you say, if you connect a corpse to a ventilator, there will be no expiration. There is no functioning there. There's no function. There's no capacity to function. So it is a fascinating topic, Dr. Byrne, and we are actually running at the end of our time here. I'm going to ask you one more question before we go and be over time. As we are Holy Apostles College and Seminary, many of the folks that listen to this program are men in formation, are men in the seminary, are priests, they're formators. What can you say directly to those who are being trained in pastoral care? What can you say to them directly? What piece of advice might you have for them?
Well, the first thing that the people in pastoral care have to always realize that they have the privilege of participating in pastoral care for a person who's made in the image and likeness of God. You mentioned earlier about the church. Many of the people who are speaking, and they wear Roman collars sometimes, they support brain death and organ transplants, and they don't separate them at all. Pope John Paul II and Pope Benedict both taught that individual vital organs, and that would include a heart, could not be taken for transplant until after death, but you can't get it until after death. So they have to get good education on these matters. Where do they get it? Well, they can go to our website, It's www.lifeguardianfoundation.org. 3 words all put together, lifeguardianfoundation.org, and they can get my presentations. If they want to learn firsthand about it, they can invite me to speak. But I have plenty of things to do, so I'm not looking for things to do. But I do want those seminarians, and I want the priests to learn the truth. In many places, they have not been exposed to the truth on these matters.
Well, thank you so much for sharing your time with me on this important and very delicate topic. I realize that much of what we said here may be very upsetting to some of my listeners, and I apologize for that. This is a very, very sensitive subject, and one that we all need to approach with prayer and knowledge. So I'm just going to close with a glory be to the Father and the Son and the Holy Spirit, as it was in the beginning, is now, and will be forever. And thank you very much, Dr. Byrne, for taking the time and sharing your expertise with us on this important matter.
Thank you very much for inviting me.
We hope you enjoyed the program and will join us back for another show on WCAT Radio. This is Sebastian Mahfood. Good day.